This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to another episode of the Neurology podcast. I'm Dan Ackerman at St. Luke's University Health Network in Bethlehem, Pennsylvania, and today I have the pleasure of talking with Trey Bateman, who is an assistant professor of neurology at Atrium Health in Wake Forest Baptist, but very soon will be joining faculty at Virginia Commonwealth University. He gave an outstanding talk at this most recent American Academy of Neurology annual meeting titled Cognitive and Behavioral Neurology Updates. And for those of you who've heard me on the podcast before, you'll know that I'm a stroke neurologist. I'm a simple plumber. And so I really appreciate the opportunity to talk with Trey about this because my patients are asking about it and I need some help figuring this stuff out. Trey, thank you so much for joining us and getting ready to clear this up.
Thank you so much, Dan. It's a real pleasure.
One of the things I'm really excited to focus on is this idea of blood-based biomarkers when we're talking about Alzheimer's disease. We've heard a lot about them, and there's been information and misinformation, perhaps, all kinds of things floating around. So first of all, in this era where we actually have things like amyloid PET imaging and regular FDG PET imaging, why are these blood-based biomarkers important, and what's really out there at this time?
The blood-based biomarkers are really important because they are so accessible. That's both their benefit and also a little bit of what makes them more challenging because they are so widely available now that there's really no friction between anyone in practice getting a biomarker related to Alzheimer's disease. Whereas in the past, like you said, you've got these advanced imaging modalities or lumbar punctures to get CSF. And so there was a little bit of a barrier to entry to get those biomarkers. But the benefit and the challenge is that blood-based biomarkers can be obtained with a simple venipuncture that we would use just like we're getting a CBC. And so these make it much easier to get information about the Alzheimer's disease continuum. But at the same time, there are just some really important pitfalls to understand so that we're utilizing them appropriately in clinical practice and not jumping the gun with getting a biomarker we then struggle to interpret in the clinic.
So with that foundation, what kinds of blood-based biomarkers are out there at this point? Because I think there's a couple of different iterations. Is that right?
Yeah, there are. They range from amyloid-based biomarkers, and so you can get some of the first blood-based biomarkers that were out there were similar to what's in the spinal fluid, ratios of A-beta 42 to 40, or just some of them report just raw levels of A-beta 42 or the ratio. There's also phosphorylated tau-based biomarkers. And the first p-tau biomarkers were the p-tau 181. That's just where the phosphorus group is located. And they were pretty good. But the p-tau 217 based biomarkers that have been around over the past couple of years have really performed quite a lot better than prior iterations in the blood. And so for the first time, we really have a group of biomarkers in the blood that are performing at around the level of accuracy that spinal fluid-based biomarkers are performing. And those are really the ones that are p-tau 217 based and probably the most commonly used in my practice right now.
So just to recap, we've got p-tau 217, which is a little bit newer and a little bit better in terms of performance accuracy compared to the prior p-tau 181. And then amyloid beta or A-beta may give you either a level of A-beta 42 or a ratio of A-beta 42 versus 40. Is that correct?
Yeah, that's right. The other blood-based biomarkers that you will see are specific to the Alzheimer's disease continuum, but you'll also see some blood-based biomarkers of neurofilament light, which we sometimes use in conjunction with these AD specific biomarkers, or sometimes used in isolation outside of Alzheimer's disease. Neurofilament light has been proposed for use in frontotemporal dementia to help differentiate, in some cases, between psychiatric disease and FTD, for instance. But neurofilament light is not specific to any particular degenerative disease. It's really just an index of neurodegeneration. And so, you'll also find glial fibrillary acidic protein sometimes, or GFAP, that's a part of some of these panels. And that's also a fairly general biomarker that indexes neuroinflammation and astrogliosis, and so not specific to Alzheimer's disease. But you'll also see those two come up in some of these panels.
Okay, so neurofilament light and GFAP, kind of like the SED rate and CRP of neurodegeneration. Is that a fair comparison?
I think that's a reasonable heuristic way to think about it.
When we are thinking about the A beta 40 ratio, if you could just remind all of us, if someone does have Alzheimer's disease pathology, what would you expect that ratio to look like?
This is one that trips up a lot of my trainees when they're learning about the biomarkers, because we think about amyloid getting deposited in the brain, and so formation of plaques that we measure by PET. And so you think about this increased signal on the amyloid PET scan. But in biofluids, both in the CSF and in the blood, you see a decrease in amyloid. So it's a lowering of the A beta 42 to 40 ratio, but also just a lowering of the levels of particularly A beta 42. The reason that you see this in a ratio is because people vary in their baseline rate of amyloid production and levels. And so you use the A beta 40 to standardize that. And as the levels of A beta 42 get lower, that ratio goes down.
Since we have these options out there, at this point, when should we think about using them? And in your talk from the AN annual meeting, I remember you talking about these two dueling guidelines, one from the Alzheimer's Association working group and then another from the International Working Group, and that there are obviously a lot of similarities and maybe some differences between those two. So can you help us know when we should be thinking about these tests and how does it fit into these guidelines?
One of the most important points that I tried to make in my talk, and that I find myself making a lot, is a distinction about what these tests can tell you and what they can't tell you. And so before I go into the diagnostic guidelines, just a point about what you're actually getting when you get one of these molecular biomarkers is they can do a pretty good job of answering, if I could look into this person's brain right now, or if I could look at their brain under a microscope, would I be likely to find Alzheimer's disease neuropathologic change? And that's what these biomarkers answer. That's not quite the same as determining what's causing the person's symptoms in front of me. And so, importantly, what we cannot do is use these biomarkers as a stand-in for clinical assessment and understanding the syndrome of the person in front of us, because that tells you a bit about what the likely causes are. So just as a for instance, we know these biomarkers are much more prevalent as individuals get older. So by the time somebody gets into their 80s or 90s, you're talking about approaching a 50% rate of biomarker positivity in people that are normal. And so you've got to understand the base rates and the question that you're actually answering. And the reason I think that's important is that what we're seeing a lot is people just ordering the biomarkers as a quick thing that you can do before actually assessing the problem. So with these biomarkers, it's helpful to think about the current diagnostic frameworks that you mentioned. And I went over both of these in my talk. That's the Alzheimer's Association Working Group, the staging criteria for Alzheimer's disease, and the International Working Group. They mostly agree in the vast majority of areas. The big area of disagreement is regarding what do we call people who are asymptomatic. And for a while now, the research framework for Alzheimer's disease has been focused on defining Alzheimer's disease biologically, based on biomarker presence. And that is separate but related to the clinical syndrome, such that you could have somebody who's asymptomatic and has Alzheimer's disease biomarkers, and we might refer to that person as having preclinical Alzheimer's disease. We would also refer to somebody who has mild cognitive impairment due to Alzheimer's disease as somebody who has prodromal Alzheimer's disease, and then finally dementia due to Alzheimer's disease. The International Working Group takes the stance that Alzheimer's disease should be considered a clinico-biological framework. And so they would not call somebody who's merely amyloid positive and asymptomatic, they would not say that person has Alzheimer's disease, has preclinical or presymptomatic Alzheimer's disease. They would refer to that person as asymptomatic at risk for Alzheimer's disease. Now, this is where it all becomes a bit of a semantic argument. The Alzheimer's Association criteria says you can't be at risk for a disease that you already have, but you can be at risk for symptoms. And so they would say that you've already got the disease, it's asymptomatic. And so you're at risk for having symptoms from that disease, but not at risk for the disease itself. And that's something that should not come up in clinical practice, but is going to, because both criteria, and the Alzheimer's Association criteria was really clear about this. They think that you can diagnose Alzheimer's disease in somebody who's asymptomatic, but as a matter of clinical practice, you shouldn't be diagnosing somebody who's asymptomatic with Alzheimer's disease. That being said, it's going to come up, and certainly has for me, folks coming in with biomarkers already done. And I would imagine for many of our listeners, they either have or will be getting people coming in with subjective concerns and wanting the test done, or they'll come in and maybe their primary care doctor's already ordered that p-tau 217 from one of the lab companies, and now they're showing up with no clinical symptoms, but a lab test that says it's positive for Alzheimer's disease.
So there's a lot to unpack there, but it sounds like part of the main point is that these blood-based biomarkers will confirm for us that there's Alzheimer's pathology present in the brain, but that doesn't necessarily mean that there's a causal link between that pathology and whatever symptoms the patient is presenting with, if any, because they may not have any. Just as a follow-up, at this point, since we don't screen the general population with these kinds of blood-based biomarkers, with this kind of testing, do we really know how often you would see a positive test in the general population at any particular age level? And if someone is asymptomatic or considered asymptomatic at risk or having preclinical Alzheimer's based on these biomarkers, what do we know about the risk of them actually progressing to symptomatic Alzheimer's disease?
Great questions and a good point there. So while we don't screen the general population in a clinical sense, we have been doing this type of research in cohort studies and studies of cognitive aging for quite a while now. In fact, this is where the concept of preclinical Alzheimer's disease began to emerge, when we started getting amyloid PET scans, were some of the first ones that we got back in the early 2000s, on a bunch of folks that were normal, and found that, well, okay, they've got this positive biomarker, but they don't have clinical symptoms. And so we've been doing this work for a couple of decades now in research settings. And we do have a reasonable idea of the likelihood of a normal person being amyloid positive by decade. And it goes up, as I think most of us probably recognize. Alzheimer's disease changes in the brain are more likely as we get older. And so it's a really low rate in your 50s, but by the time you get into your 80s or 90s, it's approaching half of normal people will have amyloid present in their brain. And the age that you're finding that at and the extent of those pathologic changes will guide whether that person is likely to get symptoms. Because people have to remember, amyloid is beginning to accumulate. The first changes are happening sometimes 2 decades prior to clinical symptoms. So if that's not starting until the 80s, that person may very well never experience any symptoms.
So it sounds like there is a framework to understand how to apply these numbers, these lab tests, even in people without symptoms. And we're talking about people being amyloid positive, but does that also include phosphorylated tau, or do those numbers differ significantly?
So this is another point that's often the confusing piece of all this. The phosphorylated tau fluid biomarkers, all of the ones that are clinically available, correspond better and do a better job of predicting an amyloid PET scan than they do the tau PET scan. And that's because the phosphorylation of tau is starting to occur well before neurofibrillary tangles are beginning to accumulate in the brain. So the phosphorylated tau biomarkers are really a pretty early stage change that we see. And the way that we often are thinking about them clinically is predicting the likelihood that a PET scan is going to be positive. Related to that, you ask about these blood-based biomarkers, do they confirm the presence of ED pathology? And I would say with some caveats they do, but there are some important reasons to be wary of false positives with blood-based biomarkers, especially it seems like folks that may have kidney injury, kidney failure, or reduced EGFR, they may be more likely to have a false positive biomarker and then would have a discordant tau PET, amyloid PET scan. So they may have a biomarker in the blood that suggests they're going to be positive, but then when we do the gold standard of an amyloid PET scan, they may in fact be negative. So there are some false positives there that are just important to be aware of.
So speaking of the risks of false positives and that there are some pitfalls to these tests, how would you counsel someone who comes in and is asymptomatic or only minimally symptomatic that has either a positive test that's already being done or is strongly advocating to have testing performed?
This is a common clinical scenario now where folks will either come in with a test that you didn't order, but you're now having to discuss and contextualize for a patient, or they may come in demanding that they get one of these tests. So let's start with the person who comes in with a test that's been ordered. The first step for me there is still to start with understanding whether this person is or is not symptomatic in an objective fashion, because that's what's necessary for a diagnosis of mild cognitive impairment. And so even if they've got the biomarker in hand, I'm not going to jump to assuming that they are symptomatic, or that if they are symptomatic, that it's even clinical condition for which that biomarker would be relevant. Additionally, I think understanding the age of that person coming in is going to be really important, because we know that the prevalence of amyloid positivity or positive p-tau 217, for instance, by decade of life goes up every decade. So that by the time you're getting into your 80s and 90s, you're 40 to 50% likely to have a positive result, just being just a normal person out in the community. So I've got to first define that syndrome, and then I've got to understand some of the demographics so that I can contextualize that for them. And if they truly are asymptomatic, then what I will usually tell them is that this is a biomarker that I may not have ordered because it's really indicated only in people who have clear clinical syndromes, clear clinical cognitive syndromes. But what it does mean is that you are at an increased risk for developing memory and thinking problems as the years pass, and that the best thing that we can do is to recommend best practices for brain health and to offer cognitive screenings going forward and keep track of how that person's memory and thinking is doing. If the person who's coming in wanting the test, really it's going to be the same way. I'm starting with trying to understand, do they have a diagnosable cognitive disorder at that time? And my practice is, if they don't, I will not order the biomarker, and I'll talk through why with them. I'll describe the current diagnostic criteria that suggest that we do not order this in people that are asymptomatic. And then I will offer referral to trials that may do what they're asking. So it's just a distinction between clinical practice and certain clinical trials that are out there. There are ongoing treatment trials of anti-amyloid therapies that are directed at individuals who are asymptomatic but amyloid positive. And so if people really want to get that information, I would provide them resources and recommendations for potential trial opportunities for that.
So it sounds like in clinical practice, when a patient comes in, we're going to start by defining their syndrome or symptom. And if there is no really definable cognitive syndrome, we might counsel them that they're at somewhat increased risk for developing symptoms of Alzheimer's disease in the future. If they already have a positive biomarker test, if they do not have a positive biomarker test, in that situation, we would typically not order one outside of a research setting, but there are research settings where this is done. And we certainly want to counsel our patients with regard to best practice to support brain health and cognition moving forward. It also sounds like you implied, and I don't want to put words in your mouth, that in this situation, we would typically not offer someone anti-amyloid therapy just in clinical practice unless they have a definable clinical syndrome, regardless of the biomarkers. Is that right?
That's exactly right. This may change in 5 years' time with some of these trials, but right now, anti-amyloid therapy is only indicated in those who have an objective cognitive impairment. And so that's just getting a positive biomarker is not enough for moving forward with anti-amyloid therapy right now. People have to have objective clinical symptoms.
One last question about this. For patients who come in and have concern and either have a biomarker done or are looking for one, and have a reasonably strong family history, and I know that's a very subjective statement, but a reasonably strong family history of dementia in general or Alzheimer's disease specifically, how does that play into the way you counsel them or your decision-making with these biomarkers?
We know that heritability, genetic history, is certainly a risk factor for many of these diseases. So I would include that in my discussion with anybody who's coming in saying that they want to get these biomarkers because of that family history. But I think there's a couple of important points in there that can lead people astray. One, these are not biomarkers for all cognitive decline. They're biomarkers for Alzheimer's disease alone. So if that person has a family history of frontotemporal dementia, then these phosphorylated tau biomarkers tell me really nothing about their future risk. And so can be misleading because it's not even testing for the right thing in that individual. So I would start by going through that this is really just a test very specifically for Alzheimer's disease. It's not a test that we can order in folks that are asymptomatic at this point. And even if it were elevated, there's really no actionable items from that. Now, the counter that people will always say is, okay, but what if it's negative? Isn't that really helpful? The negative results are pretty good. They are pretty specific in that regards. And there's a good negative predictive value for these tests. But the number of false positives that you are apt to get in a asymptomatic and undifferentiated setting is going to cause a whole lot of anxiety unnecessarily. You're going to have trouble getting the follow-up test to that because an amyloid PET scan is a much more expensive test and will, in my experience, is pretty clearly denied by insurance if you can't indicate that you're getting it for a clear cognitive diagnosis. We start ordering this just as a blanket screen to try to reassure people. You're going to reassure some people, but you're also going to lead to a whole lot of unnecessary and unhelpful anxiety for folks that you won't really have the tools to then get the next level of evaluation because they won't qualify for that.
Well, let me just restate that because I think that's such an important point. And I know a lot of people are coming to us about this because they're worried and because they're looking for reassurance. And in my entire career, I think I've had about 8 people who said that memory was their strong suit. And other than that, everybody is concerned about their memory to one degree or another. So although these tests have a good negative predictive value, they are reasonably sensitive, which means we're going to see a good number of false positives. And when you see a false positive, it's going to be difficult if someone doesn't have clear symptoms to order the more specific test that would show you that it's a false positive. So you've got this patient who now thinks they have positive biomarkers for Alzheimer's disease, but in reality may not. And now there may be all kinds of anxiety and they may make a lot of other changes based on that incorrect information. And we won't have a good way to correct it. Is that what you're saying?
Yeah, I think that's absolutely right. And I think that we all have to remember that prevalence impacts our test characteristics. And so we are only now in the past year or so getting good data on how these tests perform in asymptomatic populations or at the types of folks that are showing up without symptoms to primary care clinics. So you're going to have more false positives in that setting than when you're ordering this test in symptomatic people in a subspecialty memory clinic, for instance.
Understood. Trey, thank you so much for talking with me today and for clearing so much of this up, because I think there's a good amount of the information we discussed in this podcast that I'm probably going to use this week in my clinic and talking with my patient. And I think no matter what your subspecialty in neurology, these are questions that our patients or their families are going to be asking. So it's really important that we are conversant in this language. So consider checking out the full talk, which was Cognitive and Behavioral Neurology Updates. And Trey, we really look forward to talking with you more as this continues to get more and more interesting over time.
Thank you so much, Dan. It was really a pleasure to talk to you today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.